With a great pleasure, in this episode of Ocular Oncology Happy Hour, I'm welcome Hussain, an excellent and esteemed ocular oncologist from Liverpool University Hospital. Today, Rumana will talk us about two different cases. So we are all here and looking forward to listen her very interesting cases as always.
Hi,
Rumana,
Maria.
hi, nice to see you again.
Yeah, you too. Thank you so much for inviting me. So let me play my presentation. Can you see that okay?
Yes, fine, perfect.
So I wanted to share a case with you really about a gentleman who really took us up and down on a diagnostic dilemma. So this is a youngish guy. He's a Caucasian male, very fit and well, went to the gym, and then following going to the gym, he says his vision got very blurry. And by the end of the day, it got blurrier and blurrier, and suddenly his eye got very, very painful and his eye was very red. So he went to his local hospital, who basically said he had an eye full of blood. His pressure was very high at 80 millimeters of mercury. And they did do an ultrasound at the time, and they saw an eye full of blood. And they couldn't really differentiate if the retina was okay or not, but there was definitely lots of blood in the eye. So this is essentially what it looked like. There's no fundal view. The eye's very red, very angry, very painful, and he has lots of blood in the anterior chamber. So what they did at the time was to do a paracentesis to try and get on top of his pain and try and bring the pressure down. So they did a paracentesis. It did bring the pressure down. He felt much, much better in himself, and they sent him to the VR service. Now, we're lucky in Liverpool because we have all the ocular oncologists are also VR surgeons. So one of our oncology VR consultants saw this gentleman with the VR fellows. He had a gynae ultrasound actually rather than ocular ultrasound at the time, which is kind of more detailed, shows you a lot more structures in a lot more detail. And they saw an eye full of blood with a localized detachment and maybe a mass in the periphery somewhere, but it kind of was moving around a little bit, so it wasn't very certain. So the patient was told that he could have a tumor in his eye, but we'll send him to the ocular oncology clinic and he'll have a full assessment there. But realistically, this eye may end up with enucleation. So obviously he was devastated. You know, he went to the gym, he felt fine, and then he comes a few days later to have this diagnosis and to say that he might have his eye removed. So he came to the ocular oncology clinic, I think maybe a few days to a week later, and this is what his ultrasound looked like. So some areas of detachment, this kind of ball of blood or something in the middle. And if you kind of look at it a bit closer when you do a dynamic ultrasound, you can see all of this stuff is there, but it's moving a bit and it's not really solid. It's more kind of semi-liquid, I guess. And you've got retina here and you've got blood under the retina as well. So unlike something like this, which is clearly a melanoma, it didn't have any of these little pulsations. It didn't have a collar-stud appearance to suggest that anything broken through Bruch's membrane. And usually when you have large lesions, you would see lots of pulsations, but he didn't have any evidence of that. So realistically, we didn't think it was a large melanoma. We just thought it was very, very fluid. But let's have a look. Again, we have VR experience, so let's do an exploratory vitrectomy to see what we think when we go and have a look inside the eye. And if it's just blood, we'll clear it out. And if it's not, we'll be able to tell a little bit more about it. So he ended up with an exploratory vitrectomy, and obviously there was blood in the anterior chamber that was all washed out. He had his lens removed, and what we could see when we went into the eye is a massive choroidal and prerenal hemorrhage. Retina was detached in certain places, but it looked very, very ischemic and very unhealthy. So clearly this isn't something that's happened all of a sudden, it's something that's happened over time. But there wasn't any evidence of anything particularly solid in there. Now, the people that were in the surgery at the time were two ocular VR surgeons and one who has a specialist interest in ocular oncology. So they were quite experienced surgeons, but realistically, we didn't think we could do anything with it, and the surgery was abandoned. Would we be able to keep the eye or not? And just in case, we sent the vitrectomy sample to the cassette pathology. So why would this young gentleman, who is he's under 50 years old, suddenly get this awful choroidal and retinal detachment with so much blood in his eye? So had another conversation with him on his own. Does he use drugs? Has he ever had HIV or anything like that? Has he been abroad, have any funny infectious diseases? We kind of said it didn't look like a tumour in the vitrectomy, but realistically, the vision in that eye is unsalvageable. The retina is too unhealthy to really go and do anything with. And so we could either enucleate the eye because it's likely to deteriorate in the future, but we could just observe it. We thought we'd just wait and see what the pathology said anyway, and take it from there. So 3 days later, our pathologist phones us and says, that bag with the vitrectomy sample that you sent, it looks like this. It's staining very heavily with melanA, and it's just a bag full of melanoma cells, which is not what we were expecting at all. And so he ended up with a nucleation, unsurprisingly, and this is what we found. So this very big necrotic melanoma that's arising from the choroid that has infiltrated the retina a long time ago. So this is residual bits of retina here and here, but this is infiltrating the whole entire eye. And it's so necrotic, realistically, that's why it was so liquefied and there was no blood vessel pulsations within it. And if you look back on the ultrasound that we showed, that area of necrotic tumour actually correlates very well with the area on the ultrasound that we saw of this kind of movable, mobile area on the ultrasound. So he had a nucleation, he's got a prosthetic eye, and thankfully he had no tracking along the paracentesis tract of melanoma cells. He had no tracking along the vitrectomy sites. So we were very lucky from that instance, but just because he'd had drainage from the anterior chamber, we did treat his socket with external beam radiotherapy in case there were any cells that had seeded into the orbit from all the things that we had done, really. So necrotic melanomas, they're not particularly uncommon. You do get necrotic melanomas, but it's very uncommon for them to be so necrotic that they liquefy, really. And if they do liquefy, it's quite difficult to figure out what's going on the ultrasound. They're so ischemic that obviously you don't have any blood vessels in there anymore. They've outgrown their blood supply, and that's why you don't get a positive Doppler on the ultrasound. So I would suggest if anyone does any VR, if there's anything very unusual or untoward, that we would recommend sending the vitrectomy samples off to pathology, just in case there's anything there that you didn't otherwise expect. So that's the first case, Maria. I would, if you had any questions.
It's a very interesting case, actually. So, listening to your case, I was wondering, in which cases do you think that can occur a necrotic melanoma?
Well, obviously, this has been going on for a long time. His history is not typical of a long-standing, very big melanoma, but obviously something that's been going on for a long time. The blurred vision happened maybe a year ago, 6 months ago, and has been progressing over time. This is when you think that maybe this is a fast-growing melanoma that has outgrown its blood supply, really. So something that maybe has progressed very rapidly, you would think about a necrotic tumor. And the ultrasound is often very different in a necrotic tumor. You get your classic melanoma that has low reflectivity. If you get necrosis in it, sometimes you get patches of high reflectivity in there.
Okay. And so we are now ready for your second case.
Lovely. So let me just open up my second case. So can you see that okay?
Yes, all fine, yeah.
Okay, so this is two patients that basically taught us a little bit about differential diagnoses, I think. So this is a 25-year-old lady, very good vision, has had no problems with her eyes in the past. She went to her optician, went for a routine eye check, and the optician actually did a very good job and saw these funny hyperpigmented lesions in the eye and referred her on for further investigation. If you ask her history, she had breast cancer in the past and had a mastectomy, but didn't have any chemotherapy associated with it. She says that she's had lots of skin tumors in the past, some of which were removed, but some of which were not. And she was told that they were always benign, but didn't really have any more information on them. Anterior segment was unremarkable, and both eyes really showed these posterior pole hyperpigmented lesions that, if you look on the autofluorescence, don't really show up at all on the autofluorescence. And if you look on the OCT, you can see that they're arising really from the choroid, not from any of the retinal structures. So they're definitely hyperpigmented choroidal lesions in both eyes with no sign or evidence of activity on the autofluorescence. I thought it was very strange. And then about 2 months later, we kind of labeled her as non-specific hyperpigmentation and kept a watch on her. A few months later, we got this other lady, similar age, in her 20s, who has a history of neurofibromatosis type 1. She's had an optic nerve glioma that was treated with radiotherapy and a neurofibroma in her maxilla and face that was removed, so she had a lot of facial reconstruction afterwards. Her visual acuity in her right eye was poor because of that optic nerve glioma. In her left eye, it wasn't too bad, and she had lesion nodules in her iris. So this is her right eye, what she was referred for, but actually if you look in her left eye, she has very similar hyperpigmented choroidal lesions, very similar to the other lady as well. Again, on the autofluorescence, there's nothing that hyperfluoresces or even hypofluoresces at all, completely normal autofluorescence. And again, on the OCT, you can see these choroidal lesions that correspond to these hyperpigmented lesions. So neurofibromatosis type 1 is interesting. We know that these patients get lesion nodules, which are iris originating hamartomas. They get optic gliomas, which can give them poor vision. Orbital and eyelid neurofibromas that are related to their skin lesions. They can get neurofibromas and cafe au lait spots on their skin, as well as on their eyelids in their orbits. And they can have also this absence of the greater wing of this the sphenoid. Because of neurofibromas in the brain and associated cranial abnormalities, they can get epilepsy and seizures. So these are your typical lesion nodules, these iris hamartomas, and this large optic nerve glioma. So these neurofibromas are very common, and it's worth looking at these cafe au lait spots. It's an autosomal dominant disorder, and that's why taking a family history is essential. There are particular criteria for diagnosis of neurofibromatosis type 1 in terms of how many of these you have, how many of these you have, whether you have any eye symptoms, signs like lesion nodules, as well as a family history of neurofibromatosis type 1. So what are these hyperpigmented lesions? If they're associated with neurofibromatosis, what are they actually comprised of? And the thinking is that they're very similar to iris hamartomas in the way that they're hamartomas really of the choroid, proliferating Schwann cells with melanocytes that have formed together to create these localized areas and patchy choroidal thickening. And they're associated with different factors with regards to age, as well as whether the neurofibromatosis was diagnosed early or late. How common these lesions are varies from 70% to almost every patient that has neurofibromatosis type 1 has some kind of choroidal lesion. It's just that we tend not to look for them. And they're usually in the posterior pole rather than in the periphery. In 2015, these guys from Italy talked about choroidal abnormalities in up to 70% of patients with neurofibromatosis type 1. Again, like I said, in the posterior pole, and it was diagnostically quite accurate. So this is the non-infrared imaging of the first patient that I showed you. You can see these choroidal lesions highlight very obviously. And a couple of years later, in 2017, these guys from Germany said that there's choroidal abnormalities in up to 100% of patients. But if you look at the near-infrared imaging, then you can pick it up a lot more accurately. So almost all patients have choroidal lesions or lesion nodules, and they suggested that it is added as a diagnostic criterion for neurofibromatosis type 1. So this is the non-infrared of the second patient. Again, you can see all these hyper-reflecting choroidal lesions. So in a few years later, these guys from Italy kind of mentioned how, yes, you can detect on the near infrared on almost all patients, but not all of them correlate to hyperpigmented spots. And so only about a quarter of them have these areas of hyperpigmentation. But if they do have that, it has 100% positive predictive value. So this lady that we saw at the beginning almost certainly has neurofibromatosis type 1. So in conclusion, you've got all these hyperpigmented spots in both eyes. These tend to be hamartomas. If you can see them on the near infrared, it's almost 100% likely to be neurofibromatosis. And of the neurofibromatosis patients, almost everybody has some lesions. You may not be able to see them clinically as hyperpigmented spots, but you can certainly see them on the near-infrared imaging. So they're very specific and they are very sensitive. If we ever see them in clinic, it's certainly worth doing genetic testing. This particular patient at the beginning didn't have a family history, so it may well be a new mutation. So I thought that was an interesting case to share with you, and this is the Liverpool team that I wanted just to thank them all for all their assistance and their hard work.
Thank you very much, Simona, for your excellent case. Yes, the genetic test will be really very valuable tool. That actually I was planning to ask you. And thank you for joining us this afternoon. As a big hello to all the Liverpool Ocular Oncology team. I hope I'll see you soon, all of you. And thank you very much for joining us this afternoon with your.
Brilliant. Thank you, Maria. See you soon. All right. Take care. Bye.